I'm Sabrina Hamill, and I'm going to be talking to you guys, the class of RESPCARE 355, about using the jet ventilator in the neonatal population. So first, we'd have to talk about how we would select the appropriate patient to start the jet ventilator on. The jet ventilator was created for patients with any type of air leak syndrome, and that's sort of a blanket statement, and it covers things like pneumothorax, pneumomediastinum, pneumoperitoneum, air embolism, PIE, and sub-Q emphysema. So any patient that is at risk for developing any of those morbidities or has one or multiple would be a good patient to start the jet ventilator on. Also, patients with congenital diaphragmatic hernia, which we'll talk about later, are good candidates for the jet, or any neonate that's in hypercapnic respiratory failure. Also, any neonate that is reaching unsafe settings on your conventional ventilator would also be a good candidate for high frequency ventilation, whether that be the jet or the oscillator we'll talk about in a bit. These are just some x-rays. This is your x-ray of your CDH patient with their bowel sort of coming up into where their lungs should be. And I have a stiff lung over here on this side, so if you only have one good lung, and it's usually complicated by things like pulmonary hypertension and just being stiff and not ventilating well, you don't want a lot of pressure in your lungs. First of all, you don't want to pop anything over here, especially before they're repaired. And you also don't want to give their one good lung something like a pneumothorax, because that's how a lot of these patients end up, being cannulated for things like ECMO. And over here on your right, we just have your very basic IRDS film. Very low lung volumes, not good aeration, low compliance, hard to ventilate. This is a good candidate for the jet as well. So how does the jet work? So the jet is a form of gentle ventilation. We'll get into this in a bit about why and how that is. So a lot of times when you're using the jet, you'll use things like permissive hypercapnia. So you'll accept blood gases with a lower pH and a higher CO2. So you might accept pHs above 725 and a CO2 maybe 45 to 60, just to keep your pips lower and your mean airway pressure lower. The jet uses very small tidal volumes, oftentimes smaller than your anatomic dead space, and they combine that with a high respiratory rate, a low pip, and a small I time, and combining those things together will decrease your mean airway pressure when you ventilate, which is perfect for the type of patients that we've talked about, which is why that they would be very appropriate for the jet. Preterm infants, underdeveloped lungs, they have a lack of pulmonary surfactant, they have low compliance, they're very stiff, they're hard to ventilate, and they're also very easy with too much pressure to have them develop any type of air leak. So it's very important with these patients that we talk about ventilating them safely. So if you start seeing those patients creep up on their PIPs on their conventional vet, it might be a good discussion to have with your physician about switching them to the jet. Why does this work for CDH patients? So congenital diaphragmatic hernia, they often develop with complications to their one good lung. They have bowel in that cavity where their lungs should be, and it's very important for them to keep low pressures. It's also important that we do not bag these patients, so anything that can keep their mean airway pressure down is very important, which is why the jet ventilator, a lot of times when these patients are born, they start going right to it, because you want to decrease any chance that these patients will have a high mean. Now, there are two types of ventilators that will deliver high frequency ventilation that are common in infants, and those are the jet ventilator and the oscillator. It's important we talk a little bit about the oscillator so that you know the different types of patients that will be appropriate for each one. And these are just some pictures of the different vents. So this is your oscillator, and this is your jet. Now, the oscillator is a high mean airway pressure strategy, which is the complete opposite of what we want when we use the jet. You use your MAP, your hertz, and your amplitude to perform gas exchange when you're setting up an oscillator. The oscillator also has this equation here. Your respiratory rate times your tidal volume squared is your minute ventilation. That's different than the jet. The jet uses the standard equation for minute ventilation that we use with our conventional ventilator, which is just ventilation is your rate times your tidal volume. You don't square it. Now, the oscillator is also active inhalation, obviously, and active exhalation. It pushes air in and it pulls air out. That's bad for patients that have blebs or weak lungs that are susceptible to popping things like a pneumothorax, because as you pull that air out of them, you can very easily create a hole. And this is also often used for type 1 respiratory failure or oxygenation issues, because you can directly set your mean, which will directly set the pressure in your alveoli, which is related to your oxygenation. And the other important thing about this is it is a standalone machine and does not require the use of a conventional ventilator in tangent with it. When we talk about the jet, a lot of the things we talked about with the oscillator are now the complete opposite. This is a low mean airway pressure machine. You want to keep your mean down while you can safely deliver oxygenation and ventilation to your patient. Standard minute ventilation equation, like we talked about before. Passive exhalation. Now this is very important. So when you have the jet ventilator, if you have your endotracheal tube set up like this, you constantly have gas that's going down your tube in a swirling motion that is delivering gas to your alveoli. At the same time as this is a passive exhalation, around the outer edges of your tube, you'll have the removal of CO2 that's going up the circumference of your endotracheal tube. So if you see these arrows down the middle of your tube, you're having your gas delivery, and around the circumference you have your gas removal, and those are happening at the same time. That's very important when we talk about the jet. It's always used in tangent with a conventional ventilator, and it is often used in type 2 respiratory failure, as the jet ventilator by itself can only ventilate. Your conventional ventilator is what you will use to oxygenate your patient. And this is just a picture of the jet. This is actually the type that we use at my hospital, and one of the ventilators that you can use to combine with it. So you would use this for oxygenation, and you would use the jet for your ventilation needs. Now remember that you can definitely use both machines for both types of respiratory failure. You just have to keep in consideration the condition of your patient, any comorbidities they have, their gestational age, and the condition of their lungs. If your patient has an oxygenation issue and can take a high mean and an active exhalation, like a meconium, they may end up on the oscillator and do better. Patients like a CDH or a 25-week infant with RDS, those are patients that may benefit more from the jet, but that's not to say that you can't use them interchangeably. Now, how does the jet work? High frequency ventilation is any type of ventilation that delivers more than 150 breaths per minute. Generally, we use about 300 to 420 on our patients on the jet, depending on their size, their gestational age, and their pathology. So tidal volumes, like I said before, are often smaller than your anatomic dead space, and they use a lot of special types of principles of gas exchange to make this possible, which is sort of like the picture I drew you, where we always have pulsating down while one's pulsating up. And this happens at very, very small volumes within the machine, and it'll pulsate. And through attenuation through the tube, the pressure goes down. And it's also important to note that at the machine, if you have a PIP of 35, by the time you get down here to the alveoli, you have lost some of that pressure. There's no studies to show exactly how much pressure you lose, but the PIP you set on your machine is not the exact PIP that you were seeing in your alveoli. So, jet pulses that get dragged down the ET tube, they are delivered to the distal end of the endotracheal tube where you'll have gas exchange. And this is made possible by a special adapter. It's called the life port adapter. In the past, it used to be a special triple lumen ET tube that you'd set up to the jet, to the ventilator, and to the patient. Now we can combine the conventional ventilator to the jet and hook them up to this special adapter and ventilate through one ET tube because of the principle I showed you with air moving to and from at the same time. This is just a picture of the adapter. So your endotracheal tube would go here, the end of your jet would go here. You would have connected your conventional ventilator to your jet with just the connections that come with the machines. And then this is your life box, which would sit in your patient's bed space, connected to the jet circuit, which would then connect to this adapter. Now the controls on your jet ventilator that you can set are your peak inspiratory pressure, your respiratory rate, your I time, which we don't often change, but sometimes we can, and your FiO2. Your FiO2 can be set in both places, and it's very important that these match. Now your conventional ventilator settings are all your settings used for oxygenation. Your PEEP, your sigh breaths for recruitment, and your FiO2. So just remember, the jet ventilator only ventilates, and the conventional ventilator is only your oxygenation. And this is just a picture of a servo Y, because that's what I use at my hospital with the jet ventilator. You'd set these up, you'd have this circuit going to your patient, you would not have a circuit that would be actively hooked up to your patient here, but you would have this connected to this with some connections in the back. through these two machines, through this circuit and through that special endotracheal tube, you would have your gas delivery to your patient. Now, how do we monitor the jet? You monitor your PIP, your eye time, your rate, your PEEP, and your side breaths. Obviously, these are the things that you would set, and you would make sure that those are reading how you set them, or else you'd have to check the circuit of the patient for some kind of leak or anatomic issue. Your servo pressure on your jet is very important, as this monitors your compliance. If you have a smaller number, you are ventilating a smaller area or lower compliance, whereas if your number is larger, you have more compliance. Spikes in your servos can mean things like a leak or a pneumothorax. If you go from a servo pressure of 2 and suddenly you're at 3.5, you either popped a pneumo or something is disconnected from your circuit, and you have to find that issue. Now it goes the other way too. If you go from a servo pressure of 2 to 1, you might have a plug, you might have secretions, or you might just have worsening lung compliance, and you'd have to figure out why that is happening. Your FiO2 and your PEEP on the jet and ventilator should match. If they don't, check the circuit for water, for leaks, or check your patient for something, because something is going wrong. It's also important to know you are unable to listen to breath sounds when you're on the jet ventilator, and you will watch your patient for wiggle for ventilation. Same principle as the oscillator. If you can see the chest wiggling from your thighs to your chest, you are most likely properly ventilating your patient, and you'll monitor that by getting blood gases. Now remember to monitor blood gases, vital signs, chest wiggle, and your x-rays while you're using the jet. These are very, very important. You want to keep everything in mind, and you want to go in, look at your vital signs, look at your hemodynamic stability, monitor all that stuff very closely on high frequency, as this is usually something that we're using to prevent further escalation, like being sent to ECMO, or sometimes this is what we would withdraw care on. So it's very important that you monitor your patient very closely and hopefully get them off the jet and back to maybe conventional ventilation, and eventually to extubate them. So in conclusion, the jet ventilator is ideal for neonates who are at risk for air leak syndrome. Uses a low mean airway pressure, passive exhalation, small volumes, and a high respiratory rate. It's very important to compare these two types of ventilation. That way you know which type of patient you're going to put on which machine, who's appropriate for what. And you have to monitor and manage your patient very closely. And this is very important because many times the respiratory therapist is the person that knows the most about high frequency. We're the ones to bring it up in rounds. We're the ones to bring it up to the physician, and it's up to us to advocate for our patients. If this is the best type of ventilator that's going to work for your patient, it's very important that we bring this up in a timely manner, because capturing your patient with the jet is much more effective than a rescue setup of the jet. So keep an eye out for patients that will be good candidates for it, and advocate for it when it's needed. Thank you.